I was in the final year of my internal medicine residency when our son's classmate was diagnosed with type 1 diabetes. During a playdate, I told his dad about how continuous glucose monitors have significantly improved lives for many of my patients. I told him all about how they measure glucose levels constantly and provide better insight into glucose control, eliminate the need for frequent finger sticks, and have led to improved HbA1c and glycemic control for patients with diabetes. Continuous glucose monitors can also be used to stop insulin infusions when hypoglycemia is detected, so they also improve safety in diabetes management. I strongly recommended they look into it for their son. I even gave them a number of a pediatric endocrinologist to follow up with. When I saw them again a few months later, their son was still pricking his fingers. As a friend and doctor, I was surprised that they hadn't considered my advice. I assumed all the benefits of a continuous glucose monitor would have been a no-brainer for their family. At first, I was a little frustrated with them. Eventually, I asked them about it, and I realized my mistake when they explained that their Medicaid policy doesn't cover the device I was touting as a medical breakthrough. I read up on the issue and learned that patients with Medicaid were less likely to receive continuous glucose monitors, especially if they are Black or Hispanic. On top of that, among patients with diabetes on insulin, those uninsured or covered by Medicaid were 3 times more likely to display cost-related non-adherence. I want all my patients to experience the best possible health outcomes, but I'm starting to understand that there are many factors that can lead to adverse health outcomes, and individual patient choices aren't usually the real culprit. Sometimes, it's much bigger forces, like government policies that impact health. By discussing this topic, I hope that you will be equipped to distinguish between individual social and structural determinants of health as the causes of health inequities, describe examples of how systemic racism is perpetuated in medical care as a structural determinant of health, and discuss changes you can champion to promote social justice and create a more structurally competent healthcare system. I remember when we had a 43-year-old woman, Jackie, with morbid obesity, chronic obstructive pulmonary disease, and hypertension. Most recently, Jackie was presenting with breathing difficulties, and this was her 3rd admission in 4 months. In reviewing her chart, we saw that she was not consistently using her medications, still smoking, hadn't changed her diet, and she hadn't seen a PCP in over a year despite our recommendations to follow up after the last 2 admissions. We also referred her to the pulmonology clinic, and it looked like she hadn't followed up with them either. My attending sighed, and I could tell she was frustrated. She said under her breath, "I'm so tired of these cases. We aren't miracle workers." I was frustrated too, but I responded by saying, "I wonder why she hasn't followed our recommendations." And I truly meant that as a question. I was curious, and I was thinking beyond individual level choices and considering all the contributing factors that were out of the patient's control. On a standard H&P, I would find that Jackie was not taking her medications, smokes regularly, and is obese. However, with my expanded history, I found out that the medication we prescribed wasn't covered by her insurance, and she couldn't afford to pay $500 out of pocket. On top of that, she was having a hard time balancing work and childcare for her 3 kids and hadn't found time to see her PCP during their 9 a.m. to 5 p.m. office hours. It was clear she wanted to follow our advice to quit smoking and eat healthier. However, she also didn't have many resources to support smoking cessation and a healthy diet. She was barely getting by, and she turned to smoking and eating as her escapes. There were also many bigger structural factors that were working against Jackie. These kinds of situations can be devastating, and unfortunately, they aren't uncommon. It's often easy to label a patient as non-compliant if they aren't following your instructions closely, but we must learn to look and account for other micro and macro factors that are probably playing a role. In medical school, you may have been exposed to the distinction between social and structural determinants of health. The 2 concepts are related. While social determinants of health are the conditions in the environments where people live that affect a wide range of health outcomes and risks, structural determinants of health are macro-level, systemic, and policy issues that face populations differently and often lead to social determinants of health. Our focus today is on structural determinants of health, the entrenched policies, economic systems, and social hierarchies that make up the systems of our society. These structures can lead to poverty, which in turn can lead to health disparities and health inequities. Within structural determinants of health, you've probably heard a lot of terms thrown around. It might be useful to review what each of them means. Structural competency is the ability to conceptualize health-related social justice issues and recognize economic and political conditions as key drivers of health. In order to develop your own structural competency, you will need humility and fluency with regards to these structures. Structural humility means it's okay to admit you may not be aware of every factor that affects your patients. Only then can you seek to fill the gaps in your knowledge. Structural fluency comes as you increase your awareness of larger societal issues which limit health maintenance and compliance, so you can avoid blaming patients for outcomes that may be beyond their control. And when possible, help them access resources to combat those influences and navigate the policies that are creating barriers. As we build our structural competency, we must face the existence of structural discrimination, that is, the ways the systems that make up society were built that ignore or inflate the differences between different demographic groups, often negatively impacting historically marginalized groups. So let's consider an example. An abundance of data shows disparities in childbirth outcomes for Black and white women. Remember that health disparities are differences in outcomes that are closely linked with social, economic, and/or environmental disadvantages. Often, many of these health disparities are actually health inequities, which means that they stem from unjust or avoidable differences in treatment. One study looking at race and income found that income was a protective factor for improved health outcomes, but that protective factor excluded Black families. The study found worse maternal and infant birth outcomes for Black women regardless of income. This helps us see that the worst outcomes are not just due to poverty, but other complex issues. For decades, medical professionals have linked disease risk to race or ethnicity, which has led to race and ethnicity being used as flawed proxies for biology or genetics. Race refers to a group of people who have in common some visible physical traits, such as skin color, hair texture, facial features, and eye formation. However, these increased risks, like Black patients having greater risk of hypertension or Hispanic patients having a greater risk of diabetes, have been taught to be genetically linked and as concrete as the connection between smoking and cancer risk. Growing evidence suggests race is not a reliable proxy for differences in genetics or health risks, but that belief is still deeply embedded into the healthcare system. If we stick with these models, we ignore racism and the structures that can perpetuate inequality. Connecting race to disease was an oversimplification. For example, studies have shown that factors like discrimination and toxic stress in Black patients led to a proportional increase in hypertension, suggesting that the issue wasn't the race of the patient, but the racism that patient faced. Issues like this are ingrained all over our healthcare system, where we are failing to see the true source of the health inequities. The list of examples goes on and on. Non-Hispanic white children have been used as the normative samples for growth charts. Dermatology students face a startling lack of teaching material for diverse hair and skin types. Consider diagnostic algorithms. Many algorithms that are used to predict risk and guide physicians as they plan treatment can actually undercut good intentions for equality. These algorithms correct for race, adjusting their output to overstate or understate a patient's risk, simply because of their race or ethnicity. For example, the formula for calculating a patient's estimated GFR initially included race. Black patients were given a multiplier based on an incorrect assessment that they had greater muscle mass than white patients. This multiplier increased the likelihood of Black patients receiving better rated kidney function, which was inaccurate. For years, there were inequities noted between non-Black and Black patients. As a result, Black patients had delays in being diagnosed with chronic kidney disease, had more severe disease at the time of diagnosis, and received dialysis or subspecialty care later in the disease process. They were also sicker patients when being referred for transplant. As you can see, patients from historically marginalized groups may struggle to get the resources they need when they need them as a result of these types of structural discrimination. Due to factors like human biases and in-group mentality, it can be difficult to acknowledge these issues, and even more difficult to take action to fix them. Many of the people and organizations with the power and influence needed to change the structures are benefited by the structures. So, what do we do about this? If we can see that racism has been built into the system, and we are part of the system, one of the first steps is examining our own training and experience. What structurally biased practices were you taught? Are there any you have perpetuated? What types of structural discrimination are currently affecting your patients? Social justice is the goal of building a society that defends human rights and provides equal opportunities and equitable access to resources to everyone, regardless of which demographic groups they may be categorized into. The good news is that there has been some progress towards social justice in medicine. National guidelines are being adjusted to address the baked-in discrimination in healthcare, and some organizations are making changes in the right direction too. One interesting example is the American Academy of Pediatrics guideline for management of hyperbilirubinemia. For many years, healthcare providers were taught that Black patients had a decreased risk of significant jaundice, and East Asian patients had a major risk factor for the development of severe hyperbilirubinemia. In 2022, the AAP Board Committee on Equity and the Board of Directors denounced race-based medicine and advised its elimination from all clinical decision-making tools. The hyperbilirubinemia guideline was updated and had race removed as a risk factor. This is happening across medicine and is a positive step. However, moving forward, race-conscious medicine requires us to critically examine our past and all contribute to plan for how racism can be eradicated from our clinical work. In race-conscious medicine, we focus on racism rather than race as a key determinant of illness and health, and consider the most relevant data with the goal of mitigating health inequities. As individuals, we can support these changes and heed the changing guidelines, as well as communicate to our colleagues about the need for such shifts and hold each other accountable in non-judgmental ways. We can seek additional reading materials and training, as you are today. There are other ways of advocating for changes in the system, too. One pediatric hospital medicine fellows focused her research on understanding parents' and patients' experiences with discrimination in the hospital. She examined examples of structural discrimination as described by parents, like not having products for all hair types in the hospital or not having confidential ways for parents to report discrimination without fear of retribution. We can keep alert to find structural barriers across our society. The healthcare system, legal system, and education system all contribute to our patients' health and their abilities to achieve the best possible outcomes. The barriers in these systems usually affect marginalized populations more strongly, creating a vicious cycle. We can advocate for positive policy changes with our state legislatures, especially when we see new laws proposed that may worsen structural discrimination. Every healthcare professional in the system bears the responsibility of creating a system that serves everyone well. It is important that we move away from looking for individual faults in our patients, instead focusing first on systems of discrimination and inequality in the structures that surround us. So let's review what we've discussed. 1. Structural determinants of health are the policies, economic systems, and other institutions, judicial systems, schools, etc., that have produced and maintained modern social and health inequities. 2. Structural discrimination in the healthcare system often leads to suboptimal outcomes that disproportionately affect marginalized and minoritized populations. Assumptions and entrenched biases about racial traits can skew assessments of risk, leading to delayed, insufficient, or incorrect care. 3. Social justice cannot occur in only one system of society, and we all bear responsibility for being structurally fluent in identifying discriminatory policies and practices so we can advocate for positive change. While national guidelines and policies will need to evolve, it is vital that we champion those changes and continue to push for equitable health outcomes.